Hello, and welcome to Houston Methodist DeBakey Heart and Vascular Center Multi-Modality Imaging Conference. Today, I'm pleased to have with us two of our advanced imaging fellows who will be presenting interesting multimodality cases. I'm Dr. Dipan Shah, head of the Division of CV Imaging here, and let's get right off to it. First speaker is Dr. Payam Pournazari. Payam came to us to do 2 years of advanced multimodality imaging fellowship training from Canada, where he did his med school, residency, and cardiology training at the University of Calgary. So Payam, take it away.
Thank you. Good afternoon, everyone. So today I'm presenting a case of biprosthetic aortic valve thrombosis and discuss the role of multimodality imaging. So we're going to start with the case. The case is an 80-year-old male that presented with symptoms consistent with TIA and stroke. His past medical history is aortic stenosis, status post-TAVR, and he got a 29 millimeter core valve Evolute Pro Plus. He has non-obstructive coronary artery disease, hypertension, diabetes. He's a former smoker, history of hypothyroidism and dyslipidemia. His medications, he was on aspirin post-TAVR, however that was switched, and we'll get to the bottom of it when we discuss the case, but he was switched to apixaban. He's currently on apixaban, 5 milligram BID, pravastatin, levothyroxine, ezetimibe, amlodipine, and lisinopril. His TAVR history, overall it was uncomplicated. He got a 29 millimeter core valve, as I stated. No known rhythm issues, no need for pacemaker, or no history of atrial fibrillation. He had one episode of unsteady gait post-op day 1, which was resolved spontaneously, and there was no workup for it. This is his ECG, which showed sinus rhythm with poor R-wave progression in the precordial leads, but otherwise unremarkable. And this is his post-op day 1 TAVR echocardiogram, which shows normal LV function, normal prosthetic valve in the parasternal long view with normal LV velocity and Doppler over the LVOT and aortic valve. Preserved LV and RV systolic function and no evidence of perivalvular leak. These are the Doppler assessments at the time of TAVR, and post-op day 1 for his TAVR assessment shows overall a peak velocity of between 2.4 to 2.7 meters per second. The gradient across the valve ranged between 11 to 16 millimeters of mercury. Acceleration time was within acceptable limits, and DI was 0.75 and 0.54 respectively on day 0 and day 1. So 2 months post his TAVR, he presented with a sudden onset of gait impairment. He denied any infectious symptomatology. His CT head was unremarkable, and he subsequently underwent a brain MRI which showed acute left occipital punctate infarct. They thought this was very likely embolic in origin, so he had an echocardiogram, which I'll show the images, but showed normal prosthetic valve velocity and gradient, and his ECG didn't show any evidence of atrial fibrillation. So his aspirin was stopped, he was started on apixaban, and he was discharged home with a 30-day event monitor to look for any subclinical atrial fibrillation, and he was also referred for rehab. This is his echocardiogram with this admission with the first presentation of CVA, and showed a normal functioning valve, no evidence of perivalvular regurgitation, preserved LV and RV systolic function. The velocity and gradient across the valve overall was relatively within normal limits, and although it wasn't a great signal, the reading was reported as the aortic valve peak velocity of 1.6, a mean gradient of 6, which was lower compared to his baseline, and a DI of 0.94. His acceleration time was slightly higher, but again the velocity and the gradient was within normal limits. So then he represented in about 4 months after TAVR with right leg heaviness. He denied infectious symptomatology. He was compliant with his medication, and there was no documented atrial fibrillation on his 30-day event monitor. He underwent another brain MRI, which showed multiple acute lacunar infarcts, bilaterally left side greater than right. And his repeat echocardiogram again showed normal LV function with normal prosthetic valve velocity and gradient. So cardiology was consulted, and patient was sent for a CT TAVR workup. This is his echocardiogram, preserved LV and RV systolic function, no abnormal findings, and a normal functioning biprosthetic valve. The velocity and gradient across the aortic valve again was normal, within normal limits, with no significant change compared to his baseline echocardiograms. Peak velocity is 2.7, aortic mean valve gradient was 13, acceleration time within normal limits, and a DI of 0.66. So this is the findings of his CT TAVR workup, which showed thickening and a meniscal shape thickening across the right coronary cusp of the biprosthetic valve, involving about 50% of the leaflet, diagnostic for leaflet thrombosis, and hypoattenuated leaflet thickening. You can see the leaflet thickening in the long axis view of the LVOT and aorta. The motion of the leaflet, however, is not restricted, and so this was diagnostic for a case of hypoattenuated leaflet thickening with no restricted motion of the leaflet. This is how his CT TAVR was reported. No evidence of dehiscence of the valve overall functioning well. It opens well, however, there is 25 to 50% thickening of the right coronary cusp. So this brings us to the topic of biprosthetic valve thrombosis. The Valve Academic Research Consortium recently published some recent recommendations with respect to valve dysfunction and valve thrombosis. We'll go over some of the findings and some of the recommendations from the new AHA 2021 guidelines for valves. The consortium graded valve dysfunction to a stage 1, a stage 2, and a stage 3. And stage 1 was defined as structural changes to the valve, including thrombosis with no hemodynamic significance on transthoracic echocardiogram. Stage 2 showed moderate hemodynamically valvular disturbance, and that's all in the setting of structural abnormalities with increase in the gradient of more than 10, with an absolute gradient of more than 20 across the valve, a reduction in the effective orifice area of more than 0.3, or a change in the DI of more than 25%. This is more significant in the severe category, or a stage 3, which is a mean transvalvular gradient increase by more than 20, with a baseline gradient increase of more than 30, and a reduction in the effective orifice area of more than 0.6, and more than 50% reduction in the DI of the valve. So for our patient, he's currently in a stage 1 category of valvular dysfunction. Two new entities of hypoattenuated leaflet thickening and reduced leaflet motion were introduced with the advancement of CT techniques in patients with biprosthetic valves. The hypoattenuated leaflet thickening is a meniscal sort of shape deformity that's noticed on the long axis view of the biprosthesis valve. It's sort of categorized to 4 different categories of less than 25%, between 25 to 50%, 50 to 75, and more than 75% leaflet involvement. It is like hypoattenuated leaflet thickening, or HALT in abbreviation, is associated, may or may not be associated with reduced leaflet motion, and the reduced leaflet motion should be only attributed to in the setting of HALT. So the reduced leaflet motion is categorized also to four categories, with no restricted motion, less than 50%, more than 50% reduction in motion, or immobile leaflet. And again, for our patient, he's currently in the category of between 25 to 50% for HALT and no restricted motion. Presentation of HALT and RLM are either subclinical or clinical. Subclinical presentation is absence or mild hemodynamic changes, and absence of symptoms are compatible with thromboembolic sequelae, or they can be clinically significant, which we'll discuss about it. Clinically significant valve thrombosis is defined as clinical sequelae of thromboembolic events, such as TIA, retinal artery occlusion, or other systemic thromboembolic events, or worsening valve stenosis or regurgitation. And required to have hemodynamic significance or confirmatory imaging on the CT, such as HALT or TE imaging. So diagnosis is highly based on the clinical presentation. Like any evidence of thromboembolic events in these patients should be treated as a valvular dysfunction and should be assessed very carefully. Multi-modality imaging is key in these patients. Transthoracic echocardiogram findings suggesting of any new valvular dysfunction, especially new valvular stenosis, such as peak velocity more than 3, a mean gradient more than 20, a DVI less than 0.3, effective orifice area of less than 1.2 square centimeters, any symmetrical rounded shape Doppler jet counter, acceleration time more than 80 milliseconds, or any new transvalvular regurgitation should be considered as a valvular dysfunction. CT imaging are very helpful to diagnose HALT and reduce leaflet motion, and also they can assess for thrombus formation and visualization, and also TE is very helpful in assessing especially mitral valve, but also can be helpful in assessment of the aortic valve, especially looking for aortic regurgitation. In the setting of subclinical valvular thrombosis, it's a 2A recommendation by new AHA guidelines to assess with a 3D TE or proceed with a 4D CT imaging. It is important to recognize clinical sequelae of thromboembolic events in these patients. Any history or any presenting symptoms suggestive of an embolic event should be treated very carefully. Stage valvular dysfunction is not associated with any significant findings on transthoracic echocardiogram, and that highlights the importance of further imaging with 4D CT and 3D TE in this patient population. 4D CT is very helpful to define the structural abnormalities with higher resolution, as that's going to be the key to make the final diagnosis. The prevalence of HALT and reduced leaflet motion is reported to be about 7%. It's more common in TAVR valves, and the registry for two observational studies, for RESOLVE and SAVORY studies, showed that the TAVR valves are more involved with it, close to 7% average prevalence for HALT and reduced leaflet motion. It's more common in Edwards valve with 14% prevalence, and less common in Evolut core valves with a prevalence of 6%. For surgical valves, overall the prevalence is lower, and it's reported to be 4% Interestingly, there was a study published as a 5-year outcome in patients who got self-expanding transcatheter valves, and that study, only using echocardiogram data, only showed 0% of transcatheter thrombosis. Risk factors, the two main risk factors that was published in the studies, one is age. So older age is a risk factor for thrombosis formation, and also the higher size valve, the larger, the higher risk of getting leaflet thickening and thrombosis, and the 29 millimeter is the sort of the cutoff. With respect to significance, hypoattenuated leaflet thickening and reduced leaflet motion is associated with increased rates of stroke and TIA. It's mostly driven by TIA events, very high prevalence of TIA events in these patients' population, and that should be consistently in post-procedural and post-CT events in these patients' population. With respect to prevention and management, so these are the two new algorithms by the 2021 AHA valve guidelines, suggesting that in patients with prosthetic valve thrombosis, first of all, they should be worked up with 3D TE and 4D CT. And if the biprosthetic valve thrombosis is suspected, then they should be started on anticoagulation with a vitamin K antagonist. That's a class 2A recommendation. For patients who have a biprosthetic AVR or MVR dysfunction, then they should be on a vitamin K antagonist as a 2B recommendation. With respect to prevention in these patient population, so all the TAVR patients are required to be on lifelong therapy with aspirin, and that's a class 2A recommendation. If they are if they're not prone to bleeding, then a trial of 3 to 6 month therapy with aspirin and clopidogrel can be suggested, or they can be on anticoagulation with vitamin K antagonist. So that's a new recommendation from them at this point. Recently at ACC 21, Atlantis trial was published, which looked at the role of apixaban in patients with TAVR valves. And 1,500 patients have been randomized to 2 groups, and then they've been subsequently randomized to either vitamin K antagonist or apixaban, or single antiplatelet, dual antiplatelet agent versus apixaban. And in this study, apixaban showed to reduce the hypoattenuated leaflet thickening and reduce leaflet motion significantly. However, that did not translate to any significant clinical outcomes. Apixaban also showed to increase mortality in patients who have no indications to be on anticoagulation, and therefore the data was not favorable from that perspective. So that brings us to the end of my talk. Overall, prosthetic valve thrombosis is not uncommon. The 2 new entities of HALT and RLM should be recognized, especially in patients who do not have any clinical findings or significant findings on their transthoracic echocardiogram. There's the importance of clinical suspicions, and the use of multimodality imaging is required. There is the complementary role of CT imaging in assessment of the patients with prosthetic valve. Anticoagulation therapy reduced the risk of valve thrombosis, and unfortunately we do not have long-term data to recommend ongoing anticoagulation in this patient population.
Well, thank you, Payam. That was an outstanding presentation, and I think it's kind of interesting. It highlights how in medicine we're constantly learning. I mean, I think this was only 5 years ago when it was first described.
Yeah.
And since then, obviously, there's been a lot more that's been learned. So one thing is we've got time for a couple of questions from Payam. So for those of us that are tuned in online, you can go to pollev.com and enter the keyword DeBakey to ask your question. Or if you're on your cell phone, you can text DeBakey to 37607 and type in your question. For anybody here at Houston Methodist who's tuned in via Zoom, feel free to unmute yourself and turn on your camera if you want to ask a question. And while we're waiting for others to do that, Payam, let me ask you. I mean, I think you nicely showed that, one, this is not uncommon, that oftentimes, especially with the stage 1, that with routine transthoracic or with hemodynamic assessment, you may not be able to identify this. So the question, I guess, is, should you do some kind of routine surveillance with CT in these patients? What's kind of the current thinking on that, and what's your thoughts on that?
So I think one of the important things is that whether the CT technique is available at the sites or not. That's the availability is one issue, but with the CT becoming more and more available and ready for use, there is still no data to suggest that CT should be done on a routine basis. However, any sort of clinical suspicion of valve abnormality should be treated very, very carefully. One of the significance of this case is that this patient, unfortunately, we do not have any CT data from his first presentation because he didn't get a cardiology consult. So we cannot sort of assess, his response to apixaban at that point. But I highly suspect that he had a high percentage of his leaflet involved in that setting. So that is by itself it's important because that could have changed his presentation.
Let me ask you, for this patient here, so I mean, obviously he came in with an initial neurologic event.
Yes.
Was put on apixaban, had another neurologic event on apixaban, I presume. He was taking it?
He was taking
by history?
it? Yeah. And
so then, at that point, what did you do on his discharge? Did you switch him to vitamin K?
No, he was still on apixaban, but then his CT TAVR was worked up after he was on apixaban for 2 months. Okay. And he still showed evidence of halt but no RLM on his second presentation. So we don't know the extent of the valve involvement with his first presentation. I think with advancement in CT techniques, there could be some role in future to work up these patients, maybe at 1 year, or even or actually the leaflet thickening can happen earlier. So it could be there is a role to sort of assess these patients maybe in 3 months and see whether there's any valvular abnormalities. But we don't have enough data.
Okay. And there's a question here from the audience. The question is actually a basic question, which is anticoagulation effective to resolve this halt?
Yeah, so we have multiple studies right now showing that anticoagulation is resolving halt almost to the extent of complete resolution. But the duration of anticoagulation therapy is not known as long as to the extent as how long you're going to keep these patients on anticoagulation.
So let me ask you, obviously more, I think, data is going to be emerging, but in a case like this, with somebody who has halt, let's say you do follow-up imaging and you document resolution of that, would you then discontinue therapy on that patient, or would you keep them on it? Or how do you, or I guess, the classic thing you can always do is say we individualize the decision, which means it's a way to punt. But this patient here, what are you going to do?
Unfortunately, we do not have data. I think if they are low risk bleed, then you prefer to keep them on anticoagulation. So that's one possibility. However, we know that majority of the cases of HALT and RLM are forming within the year after TAVR implantation. So I think through assessment, still like after 1 year, and make sure that the leaflets are completely endothelialized, then potentially can be determinant of when they can come off anticoagulation.
Okay. Yeah, I think this again highlights the fact that as we have these new therapies, TAVR, we learn new things, and then we have to learn how to manage all these new entities that we come across.
Yeah.
Time for maybe one more question. If there's anybody from Houston Methodist that's tuned in via Zoom that wants to ask a question.
Dipan, this is Steve. I can ask if you don't mind.
Yes, go ahead, Steve.
So, Payam, the cases are tough, and I think Dipan asked the important question: what's the role for a screening CT? The preclinical is not really. Sorry about that. The preclinical is not so much the concern, right? I haven't had a TIA or a stroke or
Exactly.
an echo that shows some gradient change. Those are the ones where there's really the big question. Who gets a CT at 1 month, at 3 months, at 6 months? Because like you said, most of these HALT events are within the first 12 months.
Yeah.
It's a pretty easy pathway once they've got an abnormal Doppler gradient or changing gradients or a TIA to get a CT, which then if it shows HALT or reduced leaflet motion, then you have a clear plan. You're going to anticoagulate those people. But really, because of the data you just showed with the Atlanta study, we're not going to anticoagulate everybody
Exactly.
because of the mortality risk. So without the application of a screening study, such as a CT, I think the field is just sort of stalled, and we're not going to know what to do. So the study that's needed probably is let's pick a time point, 1 month or 3 months or 6 months, and everybody gets a CT, and then who have you caught? What events have you prevented with that strategy? That study may be happening already. I'm not sure, but I think that's the data that's needed.
Yeah, I agree. I think there needs to be more data with respect to serial imaging after TAVR implantation to sort of get to that point of making a clinical decision. Yeah, thank you.
All right. Great, thank you, Steve. And Payam, thank you. That was a very nice presentation and very well presented. And I think it, again, just continues to highlight the fact that in medicine, we're going to continue to evolve and we're going to continue to learn and encounter new things as we go.
Yeah.
So next, I'm going to turn to Dr. George Dibu. George is one of our cardiac MRI fellows. George came to us from University of Arkansas, where he did his internal medicine training, and the University of Florida in Gainesville, where he did his cardiology and interventional cardiology training before he saw the light and decided to come into cardiac imaging. So, George, I think you've got a very interesting case for us. I'm going to turn it over to you.
Yes, thank you, Dr. Shah. It's an honor to be here. So, I have a great case that I would like to discuss with you all. The title of my talk is based on a couple of things. One is me as a clinician. I've worked 2 years in private practice, and also now as an advanced cardiac imaging fellow. The main question is, when we get, is it best to get the right questions, to ask the right questions, or to get more answers, and what do we do with them? So what enlightens us? So I have a 63-year-old male who has a main complaint of shortness of breath. He has past medical history of AFib. He's on Eliquis for that. At least we know that he's had that for almost 4 years. It was noted on a pre-op assessment by anesthesia. He, however, reports a verbal history of a 12-year history of AFib reported during surgery before. We know that he has severe LA enlargement from an echo, and I'll get there in a second. He has hypertension, he has pulmonary hypertension, and he has a thoracic aortic aneurysm with studies showing an aneurysm anywhere between 4.7 to 5.0 in the ascending aorta. His past surgical history is as follows. He doesn't smoke less than 1 drink a day, doesn't do drugs, and he's on metoprolol, lisinopril, Lasix, and he's on clonidine that he takes as needed for blood pressure. So his known cardiac tests and labs, the ones that are relevant for us, the nuclear stress test is normal in 2017. He has a cholesterol less than 100 at 97. He has coronary artery calcification on CT in September of last year. And he has 2 echoes, and here I'm gonna show basically, if you notice, the first one is in June of 2017, the second one is in November of 2020. I do believe there were 2 different providers, if I'm not mistaken. With that being said, they show nearly the same, which is a normal EF, moderate LVH, mild RVH, normal systolic function, moderate RV enlargement, severe biatrial enlargement, moderate TR, and pulmonary hypertension with an RVSP of 66. So just as a clinician at this point, when you have such an echo and when you have such symptomatology, would you suspect something? Now after doing my cardiac advanced imaging, my differential diagnosis has broadened. So this is questions that I'm going to be asking during my presentation that I want you to think of, not necessarily to be able to lively discuss it, but as well just to entice you to think on your own. So the patient goes to the emergency room in December of 2020, and he was complaining of intermittent shortness of breath, and he had high blood pressure for the past few days prior to presentation due to bad news about his father's health. He had seen his cardiologist a month back, and that switched him from diltiazem to metoprolol, kept him on lisinopril. The BP in the emergency room was 217/126. The heart rate was irregular, and the BMI was 25. As you can see, the EKG is showing a fib. That's rate controlled. Nothing at this point that I can add more than that per se on this EKG. The patient gets labs. I'm sorry, maybe they project small, but basically I can say that the creatinine was normal at 0.8, electrolytes were unremarkable, and then the CBC was unremarkable. You can see that he had a BNP of 338, and the troponin was 0.032, and this was at 6. And then 3 hours later, he had a troponin of 0.036. So the patient gets a PE protocol, and this is also a lesson for all of us as well, that we usually go for the conclusion. It's important to read the body of the report as well. And you can see the heart is moderately enlarged, on the right, particularly on the right side. The ascending aorta is dilated to approximately 5 centimeters, and then you have reflux of contrast into the IVC, and the hepatic vein represents right-sided cardiac insufficiency. No PE, and then the rest as you can see. So the patient, while in the emergency room, he receives news about his father passing. So they had given him clonidine for high blood pressure. They recommended him to adjust his blood pressure medication. They talked to him and they discharged him. So as a clinician, would you discharge this patient? Yes or no? Knowing his labs, knowing his presentation. And then what's the next step? Well, the cardiologist that he had seen, he had already ordered a cardiac MRI on him. And the reason why he ordered a cardiac MRI, he was suspecting infiltrative disease such as amyloid. So do you agree on that? Would this be your next step? So the CMR, the cardiac MRI was done in January, a month later, a little bit less than a month later. As you can see, the MRI here, so we take short axis cuts basically from the base to the apex. You can see that the LV function is preserved. The RV looks big. You can also see here in the tricuspid, you can also see almost an effective regurgitant orifice, which implies there will be some TR. And then as you go to the apex, you notice actually that the apex is getting thicker, which is unusual. Now, if we look at this now, we can see this is the 3-chamber view, which is equivalent to the parasternal long axis on the echo. This is the 2-chamber view, and this is the 4-chamber view. You can clearly see that the apex is thickened on all views, and you can see there is a thinning of the apex here, and which looking at the other pictures, this is a small apical aneurysm. Clearly, both atria are severely dilated, Also, there is an apical systolic cavity obliteration, and the TR is evident. We cannot quantify from this, depending on the sequence that we do. We don't quantify just visually, but it gives us an idea that definitely there's a TR with the dilated annulus. Also, you can see here in the between the atria that there might be some shunting happening. It's not 100% clear, but you could begin to suspect, and it's important to point out a small pericardial effusion here. So what we do next is we do what we an atrial septal defect assessment. We take sagittal cuts, as you can see, and then we cut it all the way, and then you can see that clearly there is a moderate size ASD with shunting here. So this gives us basically better assessment about the rims. It gives us better assessment about the size and where the shunting is going, which eventually we will assess the flow of that ASD by looking at what we call phase contrast images. So in MRI, we're able to quantify the flow, and you can see we do in-plane flows for that ASD. We do through plane flows, so the flow is coming at you, and we determine a velocity. I'm not sure if it's showing. We determine a velocity of 150, so this way we can see it would be higher than the velocity where the flow might alias. So by tracing this, and obviously we're getting the aortic flow, the PA flow, which would get us to calculate the QPQS. So with that in mind, and then we have those information, we can trace this different phases in the cardiac cycle, and then what we do is we come up with a flow, and we will assess the through plane flow across the ASD, and now we know the flow across the ASD. We can also measure the ASD. It's one of the ways we can measure the ASD as well. Now, moving on from here, we did assess the aortic forward flow, the PA forward flow. We did assess the MR and the TR. Another strength of the cardiac MRI is the LGE, and basically late gadolinium enhancement is assessing scar. This is one of the main strong points of MRI, and it tells us here, it shows us that the apex has a scar in the apical inferior and the apical anterior, and then there's transmural over the true apex, and this is the area of the small apical aneurysm. So as part of the reporting and being thorough, the RV is severely dilated. We have a normal pump function. We have an LA that's severely enlarged, and also we measure the thickness of the muscle, and we came up at 1.4, and this is important to keep in mind. And this is, as you notice, we do the same measurements as in the echo, the interoceptum and the inferolateral walls as well. So the report of the CMR, which we communicated with the provider, it was apical hypertrophic cardiomyopathy with a small LV apical aneurysm, the scar especially in the apex, also in the superior and inferior RV insertion site. And this is important because these are findings that we see in pulmonary hypertension. There is no evidence of ischemia, and in HOCM as well. No evidence of ischemia. I did not show the stress test, and it's important, which I don't think I'm going to have the time to discuss. There is a large secundum ASD. The measurements is 2.3 times 1.3, and there's a large left to right shunt with a QPQS of 2.9 and a severely enlarged right side. Severe functional TR, mild to moderate MR, and the aorta that's dilated, which we know about from previous CT scans. The patient gets a follow-up visit with his cardiologist almost 5 days after the CMR. This is going to probably project very small, but the first arrow shows that it mentions that the patient does not have amyloid, but they did see the ASD and the apical HOCM. The second arrow shows that as part of the next step, they would like to do a left heart cath and right heart cath and a TEE for the ASD. They did increase his furosemide, and they adjusted his medication for the blood pressure as well, and he was doing fairly well at the time, and they sent him for left heart cath, right heart cath first. I don't have the pictures, these are outside hospital, but I have the reports, and what's important to note is the mean PA is at 42, The LVEDP is at 24, and this is extremely important. The QPQS is at 1.7 and 1.8, which is a little bit less than the it's less than the one that quantified in MRI, but I think some of it must have been from the Lasix and the blood pressure control that he's had. Also, there's a step up of 14.9% on the oxygen saturation, and we know that anything above 5 to 7% is a significant step up. He gets a TEE, and as you can see here, this is the mid-esophageal view with four chambers that you're seeing. You have mild MR on this view. You have at least, I could say, moderate to severe TR on this view. And this is pictures of the ASD itself, and as you can see, there's left to right shunt. It's a moderate size ASD at least, and we can see that this is the pictures of the defect, and then this is where we're measuring it at 1.3, which is consistent with what we got on the MRI. So the TEE basically comes back as normal EF, severe TR, severely enlarged right atrium, and then that ASD that we saw. So what is the next step at this point, now that we have the data? So we have the answers, but what are the questions that we need to ask, and what's the next step that we need to take? The patient gets referred to Houston Methodist Hospital, the central location here, and he gets seen by our team. And he, according to the note, he was initially seen by Dr. So-and-so for AFib in the setting of pre-op eval 3 years ago. He does notice that his exercise capacity has been declining for 15 years, and he's been told that he had a murmur as a child. The assessment and plan, which included and listed all the problems that this patient have, basically was to give him an event monitor for 30 days, refer him to EP to give a shot at fixing the AFib, and eventually do a transcatheter ASD repair. And the most important thing is have a multidisciplinary discussion given the fact that this patient has apical HCM, ASD, and in the context of pulmonary hypertension. And this is very important. This is one of the things that in Methodist we do in order to provide the best care for our patients. Moving on, the patient gets a referral to the hypertrophic cardiomyopathy clinic, and as you can see that the CMR findings were consistent with apical HCM and apical aneurysm. The scar and the apical aneurysm, they put the patient at high risk for sudden cardiac death, so there was a discussion of the ICD implantation, and rightfully so, the assessment of the physician that saw him showed that the ASD, concluded the ASD, the severe TR, and the AFib are major contributing factors to his symptomatic status, which I guess at this point we all agree about. He does see the electrophysiology team. They discuss with him the AFib ablation, including the vein of Marshall ablation. If I have time, I'll discuss it later. And basically, they discuss with him also the ICD, and they tell him that they need to see what the monitor will show. Now, if you notice, he was given a 50% chance of success, and rightfully so. His LA is severely enlarged. And at this point, we will talk about it, but the diastolic dysfunction is very important in this patient, and we'll discuss that. He gets the EP procedure done with a loop in place, a pulmonary vein isolation, vein of Marshall ablation, and then he gets an ECG at discharge, and the ECG shows that he's in normal sinus rhythm. I want to point out this, which is the giant T-wave inversions, which is extremely important, especially in our discussion later on about apical HCM. 2 days later, the patient comes back to the emergency room. Now he has shortness of breath, swelling, 15-pound weight gain, and he tried to take extra Lasix. It did not work. His ECG showed normal sinus rhythm, and his X-ray as such shows enlargement of the cardiac silhouette, possibly pericardial effusion, interstitial edema, pulmonary edema, and then tortuous aorta. So the patient gets admitted to the hospital, and he stayed there for 4 days. He gets labs done, and I'm sorry I did not mention it earlier on the cath, I did not point it out. He had non-obstructive coronary artery disease with 20-25% of plaques. And yet you can see we checked the troponin. As clinicians, what's the meaning of this troponin? Did we need to check this troponin knowing that he has non-obstructive coronary artery disease as one? Two, we just did an ablation on him and the vein of Marshall ablation as well. So he gets a PE protocol unchanged from prior with a negative PE, and the dilated pulmonary system. And he gets a TTE. This is the first one in our system. I know that I mentioned earlier on there was another one, but this is the first one. So you can see that these are the parasternal long axis images on the first one. The heart is thick. It looks like a preserved function. It's hard to assess just from one view. The RV is dilated, likely depressed function. The LA is big. This is your tricuspid valve, and you can see that the annulus is dilated. Also, you can see that on this incomplete envelope for the TR, your RVSP is not fully estimated here, but at least 3 meters per second. And you can see there's moderate to severe TR from the color Doppler that you're seeing. This is the short axis view of the aortic valve, and we're focusing now on the right atrium and the interatrial septum. So you can see here that there's the moderate to severe TR. I would argue that it's a severe TR at this point. And there is a small jet that you can see here, the color Doppler I meant, and this is in the interatrial septum, which is consistent with what we know about the ASD. Now, looking at the fourth chamber, we still see that small posterolateral pericardial effusion behind the right atrium, the severely enlarged severe biatrial enlargement, the LV that's normal function, the RV that's dilated with depressed function. The TR was at 4, and the RVSP now is at 70, which is consistent with his history of severe pulmonary hypertension. Diastolic dysfunction is very important in these patients. Obviously, we have, if we go by the guidelines, you have a severely enlarged LA, about 34, obviously bigger in this case. TR, which is elevated. And then you look at the septal and the lateral E prime. A low lateral E prime, a very high E, a short deceleration time, and elevated filling pressure by doing the E over the E prime. So now we're talking about an advanced diastolic dysfunction, grade 3. It's hard to say specifically, but grade 3 in that regard. And then the interatrial septum, that is basically showing, again, another picture of the color Doppler. Now, what's very important, and this is important to also teach our tech and as clinicians, you can see that here on the LV, where this is a 3-chamber view of the LV, and you see the slit-like appearance of the apex, but it's not that very clear. I mean, sometimes you can just, if you're reading quick, you can just say LV function is normal and move on. But rightfully so, and this is part of our protocol here in Methodist, is giving contrast to the patient. And this demonstrates beautifully the contrast going into the apex with the slit-like appearance, and then you see the small apical aneurysm that's here. So the TTE report was as expected. The EF was normal. Basically, on the left side, the RV has depressed function, severely enlarged, and now you have the large secundum ASD that we know about. And the moderate to severe TR with an RVSP that's very elevated. So during the hospital stay, the cardiology was consulted, and basically they diuresed him. The troponin, as we discussed, it was secondary to the AFib ablation. He was transitioned from heparin drip eventually back to his anticoagulation, and the echo showed that small pericardial effusion that we talked about. He felt better during his stay, which was very important. The patient only had 3 beats of non-sustained VTAC and sinus bradycardia. The troponin was downtrending. He was switched to PO Lasix, and he was discharged on the 3rd, as I said, 4 or 5 days later. He had a couple of cardiology follow-ups in between, and basically on the 4th, in April of 2021, the patient was found to be in A flutter. So he was taken on the 11th of May for an A flutter ablation of a typical flutter. And it was discussed with him to proceed. I think he was scheduled, if I'm not mistaken, a week later or 2 weeks later for an ASD closure, but the patient asked to postpone it due to him traveling, and there is a plan on closing the ASD in August. So the questions that I asked myself when I was doing this, as a clinician and an advanced imager, do we close the ASD and then deal with the AFib? Well, if we do so, then you have a device, and you have to cross the device. And actually, one of our attendings discussed this with thoroughly, and it gives you thoughts to say, well, should we then give him a shot to be in rhythm, in normal sinus rhythm, like he was, and then close the ASD? What is the management of apical HOCM and the ASD, especially in the context of pulmonary hypertension? Do we give this patient ICD or not? Now, what is the vein of Marshall ablation? I do not think I'll be able to discuss it, but the pioneer of this is here, Dr. Valderrabano, with the Venus trial. And should we have approached this in a different way, and why? So let me discuss a few points for teaching purposes and for discussion purposes. Apical HOCM is a heterogeneous group of muscle disease where we detect left ventricular hypertrophy in the absence of abnormal cardiac loading conditions. It's due to autosomal dominant mutation, and there are several variants that are described with the picture being here: the sigmoidal, the reverse curve, the apical, and the neutral, with the asymmetrical being referred to as the classic HOCM. So this is a summary of basically the differences between classic HOCM and apical HOCM. I would like you to concentrate on this at this point. So 10% in the non-Asian population, the prevalence. 41 is the mean age of presentation. The EKG characteristic giant negative T waves, which I had already shown you. A voltage criteria for LVH. AFib is relatively common, and non-sustained VTAC. The mutations are less than in classic HOCM, and you have associated morbidities of AFib, diastolic dysfunction, pulmonary hypertension, ventricular arrhythmias, and the all-cause mortality rate is nearly the same, taking into consideration the prevalence. So it was first described in Japan in 1976. Initially, it was described on an LV-gram where they see that unique spade-like configuration and marked apical obliteration with the ECG of the giant T waves and the high QRS voltage. But now what we do is we measure the wall thickness in the apex. It's 15 millimeter, or a ratio of maximal apical to posterior wall thickness of more than 1.5, based on the echo or the MRI. Typically, because the hypertrophied segment are in the apex, there is no LVOT obstruction from SAM of the anterior mitral leaflet. There is no associated MR or minimal. You can or cannot have mid-ventricular obstruction and cavity obliteration like this patient, with or without apical aneurysm formation, like this patient had it, and can be subclassified into three forms. One is if you have it isolated to the apex is pure, mixed if you have it with septal hypertrophy. And it's very important, we've had a couple of cases, at least in the last 2 weeks, of relative apical HOCM, where it's believed to be an early apical hypertrophic cardiomyopathy phenotype, which when you have the ECG characteristic of T-wave inversion, you have that loss of the usual apical thickness tapering that we usually find, and the thickness is increased. However, it does not meet the criteria of 15, and you have the associated pathology that you look at, which are the LA dilation, the apical aneurysm, and the myocardial scar. So this could be a marker of early disease that could progress with time, and it's important to re-image the patients. These are the giant T waves that I talked about. This is the MR findings, just like our patient with the apical LGE and the apical systolic cavity obliteration. And the Holter, that's very important, that shows AFib up to 28% in these patients, non-sustained and sustained VT respectively as above. And the reason for the VT, it's an aneurysm. It's possibly related to re-entry around the aneurysm. And the very important point that I would like to point out, the LA enlargement secondary to LV diastolic dysfunction at the time of first presentation of HOCM predicts later AF. So here it's the chicken or the egg. Like basically the diastolic dysfunction, your LA is big, and now prediction of more AFib, or vice versa. The patient has AFib, your LA enlarges. So, and that's where also the EDP was elevated. AFib and HOCM guidelines in 2020, you can see that the antiarrhythmic medication, they're modest at best, and then the best one is amiodarone, but however we know the toxicity of this medication on the long term. Also, what is the guidelines for HOCM and AFib ablation? So we can see here in patient with HOCM and symptomatic AF, as part of the AF rhythm control strategy, catheter ablation can be effective if the drugs are ineffective, if there's contraindication or patient preference. And this is a 2A level of B evidence. The apical aneurysm, I'm going to skip all this, and I want you to concentrate on the last 2 points. There is a risk of apical thrombus formation and thromboembolic stroke, and it's considered the arrhythmogenic substrate for patients. The important part, and as I had mentioned about contrast and part of our protocol here, apical hypertrophy was missed by echo in 40% of the cases that was later detected by CMR. Late gadolinium enhancement is common in HOCM, and usually it's apical or subendocardial. And this is the strain pattern with the apex being affected. Obviously, slit-like appearance. I'm going to skip the Doppler. This is the mid-cavity obliteration, and then these are the MRI findings that I've already discussed. For MRI, what are the HOCM guidelines for MRI, and when is MRI indicated? It's indicated when the echo is inconclusive, class 1. It's indicated when you're suspecting infiltrative disease. So our colleague, cardiologist, who referred him was right, basically, because he was suspecting an infiltrative disease at the time. And basically, if you have other, you need more features or more findings to support whether you give him an ICD or not, and you give the patient an ICD or not. So as we know, and this is from the 2020 guidelines from the HOCM, this is if you have sudden cardiac death, VFib, sustained VT, obviously it's a class 1. If you have any family history of sudden cardiac death, if you have massive LVH, which is usually defined more than 30, unexplained syncope, apical aneurysm, EF is more than less than 50, and it's reasonable. And then if you have non-sustained VT, so ordering the event monitor, looking for NCSVT, and the assessment of our colleague in the HOCM clinic saying apical aneurysm, and the scar, which is 15%, is an additional marker to help us guide the decision for ICD. The last thing that I'm going to be showing is basically the ASD. You know, the QPQS more than 1.5 is considered as significant. And then you look at the shunting. If it's right to left and an Eisenmenger syndrome, then you have to refer him to congenital and pulmonary team. If it's a left to right, then you look at the hemodynamic assessment. You look at the PA pressure and the pulmonary vascular resistance. If it's less than a third of the systemic vascular resistance and the PA systolic pressure less than 50%, then and the QPQS is elevated, then we close surgically or device closure, class 1 or class 2, depending if there's function impairment or not. And then if the pulmonary vascular resistance is different, or it's more than 50%, then we need the congenital heart disease, which were involved and are still involved in the management of this patient. And this is where multidisciplinary approach at Methodist is providing the best care for our patient. And thank you.
Well, great, George. That's a very nice case. And again, we've got time for 1 or 2 questions. Anybody tuning in online, if you go to pollev.com, enter DeBakey, or text the word DeBakey to 37607. And also, if we've got anybody here at Houston Methodist on Zoom, please unmute yourself and turn on your camera, and we'd love to hear from you as well. And while we're waiting, George, I mean, I think this case, this is, kind of a doozy of a case. I mean, you've really got 3 different conditions going on in this patient. You've got apical HOCM, you've got an ASD, and then you've got pulmonary hypertension and atrial fibrillation. And I think that, the one thing you pointed out, I think, which is very important, which is that if you're going to take a strategy of saying, I'm going to fix the AFib and the ASD, I think that's where obviously you want to go after the AFib first, more from a practical standpoint, which is you can't cross the septum once you put an atrial septal occluder device. Okay. I guess a question to you is, I know you mentioned that they quoted about a 50% success rate with ablation. In a case like this, do you think that's still the case? Because even if you can fix the ASD, you do an ablation, you fix the ASD, he's still going to have increased LV and diastolic pressures from this apical HOCM. This LV myocardium is abnormal. Yeah. And so he's got kind of multiple insults that are putting increased pressure on that left atrium.
Correct. Right? So, yes, exactly. And this is where I pointed out the LVDP and diastolic dysfunction in my comment about the LA enlargement, basically from the diastolic dysfunction, which eventually later predicts the AFib. I think at this point, I thought a lot about this case, and I do agree with giving the chance for this patient to put him in rhythm, which they did and successfully did. And keeping him in rhythm, this patient has diastolic dysfunction. This patient has pulmonary hypertension. This patient has valvular heart disease. Like we discussed, multiple issues. Restoring normal sinus rhythm is, I should say, one less problem to deal with at this point, and he was symptomatic from it. So this is from that regard, I would definitely encourage the AFib ablation first. Also, I think crossing with, like you said, with the device and the septum is extremely difficult. Can be done, but it's extremely difficult. And the last thing I would say, and which I did not point out to, if we put him in normal sinus rhythm, which we did, and then we close, we hope to remodel that right side, and eventually that TR is going to improve by closing that ASD, and hopefully that the dynamics of the heart, and obviously good blood pressure control, controlling his risk factors very, very well, eventually giving him an ICD is the right next steps. Yeah,
I think this is a complex case and really requires kind of a multi-pronged approach as far as how to treat him. And I think it's going to require close observation and close follow-up as well. Okay, so we're a couple of minutes over time. I want to thank you, George. I want to thank you, Payam.
Thank you for having me.
Both for really outstanding presentations, very insightful and very well done.
Thank you.
And we look forward to seeing everyone back here again next Tuesday. Thank you.